Hello and welcome. We are so glad to have you here with us today. It is my distinct honor to be able to introduce this neurological considerations for our transplant kiddos. We have long wanted to do this session, so I am so happy to have Dr. Kelly Wolfe and Dr. Elise Turner with us, both pediatric neuropsychologists from Colorado Children's Hospital. I will bring up Dr. Wolfe now. Hello, Dr. Wolfe.
Hi, hello. Thank you so much for having me.
We are so honored to have you with us. I am going to go ahead and start your presentation momentarily, and then we'll take questions and answers afterwards from the group. So feel free to put those questions in the chat and we'll make sure to answer them.
I look forward to answering your questions. Thank you. Kelly Wolfe, and on behalf of my co-presenter, Dr. Elise Turner, we are delighted to be here to talk to you today about neurological and neurodevelopmental complications in pediatric solid organ transplant. We have no financial relationships to disclose for this talk. To go over what we hope to share today, we will first start with an overview of the research on neurological and neurodevelopmental comorbidities in children who have gone through heart, liver, or kidney transplant. And we'll go over why we tend to see neurodevelopmental consequences after these procedures. We will then go through kind of development as a whole, from early childhood to kindergarten and school entry, transition to middle school, and then high school, and then even transition to adulthood. We'll discuss what developmental milestones tend to come up for children, particularly after solid organ transplant at these times. And we'll talk through what can be done at home, as well as resources to leverage in the school and in the community to optimize each child's neurodevelopment. To start, to kind of frame this conversation, we want to acknowledge that incredible medical advances have improved survivorship in pediatric solid organ transplant over the past several decades. And because of this, we are starting to redefine positive outcomes or successful outcomes in terms of quality of life beyond just survivorship. Quality of life is a broad construct that can include social and emotional well-being, medical and physical health, as well as neurological and neurodevelopmental health. And today's talk will focus mostly on social, emotional, and neurodevelopmental aspects of quality of life. In pediatric heart failure and transplant, we know that even prior to transplant, mild to moderate delays have been documented in children's cognitive skills, their language, as well as their motor skills. And most of this research is done in infants and toddlers who are listed for heart transplant. Post-transplant, we see those mild to moderate developmental delays persist. This results in, as a group, lower overall intellectual functioning, about kind of one standard deviation below the mean or in the low average range. We tend to see more difficulties with learning and memory skills. Processing speed or cognitive efficiency can be slower in these children. We certainly see increased difficulties with attention and concentration. In fact, one study noted that 1 in 3 children who had had heart transplant had a diagnosis of ADHD. Along with that, we noticed difficulties with executive functioning. For example, planning, problem solving, and organizing. Those are aspects of what we call this executive functioning set of skills that tend to come online more in adolescence and early adulthood. And these cognitive difficulties that I've described tend to result in downstream difficulties with independence in day-to-day life, which is what we call adaptive functioning, as well as some difficulties with academic learning and academic performance. There are multiple reasons that contribute to these neurodevelopmental difficulties after pediatric heart failure and transplant. The first is that we think that there is reduced nutrient and oxygen delivery to the brain when the heart is not pumping correctly. And so for children with heart failure of either congenital heart disease or cardiomyopathy requiring heart transplant, that probably impacts some of that nutrient and oxygen delivery to the brain. Children who need heart transplant are at increased risk for neurological comorbidities like stroke or seizures. and may have to go on ECMO for support. We know that during a heart transplant, the cardiopulmonary bypass machine can result in little tiny microemboli that may travel up to the brain and cause tiny areas of punctate foci or micro injury to the brain. One study at least suggests that increased rejection episodes after heart transplant may be related to increased cognitive problems as well, particularly in memory. And finally, for those children who had congenital heart disease prior to requiring a heart transplant, we have research from the CHD world that abnormal or different brain development kind of starts in utero even, with slowed development and smaller brain volumes, again, related to kind of reduced blood and oxygen delivery to the brain, even during the fetal period.
All right, so I'll talk next about kidney transplant. And I'll start by saying that most of the research in this area has really focused in that post-transplant phase. But there has been a few select studies focusing in the pre-transplant phase. For those working with infants in early childhood, those studies have shown developmental delays in cognition more broadly, but also fine and gross motor skills. For those focused in school-age children, we've seen some differences in intellectual function or on IQ testing. So again, similar to what Dr. Wolfe had mentioned, IQ in this population can fall more in what we consider that low average range. We also know that kids who are undergoing a kidney transplant can experience cognitive weaknesses or developmental differences that are more common in the broader chronic kidney disease population, regardless of transplant status. And those set of weaknesses I actually have focused in here on that post-transplant phase box. So in the post-transplant phase, we see a really similar pattern on IQ testing. We can also see some challenges with processing speed, meaning a kid may take a little bit more time to get things done. We can see increased difficulties with attention and concentration, with higher rates of ADHD being more common in this population, as well as executive function difficulties, which I'll talk about more in a future slide, but again, are all those skills that a kid needs to complete a task. And we can also see memory challenges and higher rates of learning disabilities or academic challenges. And on my next slide, I'll talk a little bit about why we might be seeing some of these developmental or cognitive difficulties. So one of the main functions of the kidney is to clear waste and balance other substances like electrolytes or proteins in the bloodstream. And so when that process is disrupted, you can see higher levels or even harmful levels of these waste or protein products circulating throughout the body, including into the brain. And when there are harmful levels, this is what we call neurotoxicity. So this can contribute to some of these developmental or cognitive difficulties, but can also lead to more overt neurological complications like seizures and strokes, as well as differences or abnormalities on brain imaging. And those neurological complications themselves can pose some risk for cognitive challenges. High blood pressure or hypertension is really common in kidney disease. And in particular, hypertensive crises or more common hypertensive crises can contribute its own set of risk factors for cognitive difficulties and can also lead to stroke. Some research also suggests that longer time with end-stage renal disease or longer time on dialysis leading up to transplant can pose some risk for cognitive or developmental differences post-transplant. And other work has focused on comorbid conditions and their contributions as well. And in particular, prematurity in this population has been linked to ongoing challenges with cognition over time. I'll next talk a little bit about liver transplant. So most liver transplants occur in infancy or early childhood. So a lot of the pre-transplant research has focused on this age range. So in infants and toddlers, we've seen delays in overall cognition, more of gross motor skills, which includes balance and coordination, learning to crawl and walk, as well as expressive language. So a child's ability to communicate or express themselves with language. School-age research has focused on intellectual functioning or IQ testing, and again have seen this pattern of kind of more low average IQ functioning. In the post-transplant phase, we see again a really similar pattern on IQ testing. We see challenges with attention and executive function, as well as higher rates of ADHD. Some of those language challenges that we can see pre-transplant can continue on in the post-transplant phase. We can also see difficulties with more visual or spatial skills. So this is a child's ability to process visual or spatial information to do things like complete a puzzle, understand a visual graph or design, and then draw different designs or figures as well. We can also see higher rates of learning disability across subjects in liver transplant patients. So in thinking about why we're seeing these patterns of challenges, one of the primary responsibilities of the liver is to make toxic substances in the body harmless. So when there is liver failure or dysfunction, there can be a buildup of these toxic substances, and in particular neurotoxins, including ammonia. And what neurotoxins are is they're harmful to the brain in particular. So they can alter the cells in the brain metabolism, and cause inflammation that all can directly impact development and cognition. When there is brain dysfunction secondary to liver failure or disease, this is sometimes called hepatic encephalopathy. And this really includes a spectrum of symptoms. At the more milder end, there can be some of these developmental or cognitive differences. And in the more moderate or severe ends of the spectrum, there can be more overt neurological complications like seizures or stroke that again contribute on their own to cognitive challenges. Some research has also shown that evidence for malnutrition, including kind of lower weight or poor growth pre-transplant, can pose risk for cognitive challenges post-transplant. And so I think next I'll be passing this back over to, oh no, one more slide. So on this slide, I'll talk about the transplant process more broadly. So after a solid organ transplant, we don't expect any regression or loss of skill in terms of cognition. Instead, we really expect cognitive functioning or cognitive skill development to stabilize. When kids are stressed, fatigued, or physically aren't feeling well, there can often be kind of a cognitive fog where maybe they have a harder time concentrating or remembering things. And so that can be common in this population leading up to transplant and immediately post-transplant. But after that cognitive fog is gone, again, things really start to stabilize and kids can benefit from the interventions that they're receiving, like their therapies or academic supports, because they're more readily able to engage in these activities and benefit from them. On the right-hand side, I have a list of kind of common risk factors for cognitive challenges across our solid organ transplant patients. So the earlier a child presents with their disease, the more severe that disease is, and the longer they have that disease leading up to transplant, there can be a higher risk for cognitive difficulties over time. If they have a longer hospital admission, which is usually indicative of some sort of complication or neurological complication in general secondary to their disease, that also poses some risk. And then any comorbid medical conditions may also have their own set of risk factors. I know I've talked through prematurity in our kidney disease populations, but metabolic disorders is also common in these populations as well. The last piece that I'll talk through is the impact of medications. So it's really hard to study the direct effect of the different medications kids may be on, like tacrolimus, on their cognition and development. So there's a lot of risk factors going on at once, so really disentangle what medications is contributing is difficult. However, we know that these cognitive difficulties can present prior to transplant or before initiation of these medications and really stabilize or don't get worse over time. So it's really unclear if medications are contributing to cognitive challenges. And then now I'll pass it off to Dr. Wolfe again, who will talk about early childhood, some challenges in this time period and how to support kids.
Thank you so much. Rolling into early childhood, some of the skills and milestones that we think about during this developmental period include cognitive development. For example, children are beginning to explore their world and lengthen their attention span or ability to focus on one task. They're starting to develop their memory skills. For example, if you promise dessert after dinner that night, they're going to start to remember that. And also to figure out problem solving, how to fit a shape into a shape sorter, or how to fit puzzle pieces back into a box. Kids are also starting to develop their understanding or receptive language skills, which tend to come online first, and also their expressive language skills. We think of expressive language as being comprised of both articulation, which is more of the motor coordination, being able to pronounce words, and separately, their language expression, which means their vocabulary and ability to string together words of increasingly longer phrases. For almost all children, they are able to understand more than they are able to say at this developmental stage. But the discrepancy or the difference between those two skills can vary a lot, with some children understanding much more than they are able to say, and others being fairly close in those two areas. In terms of motor skills, we think about feeding as being an early motor skill from very early on, of course, whether it's breast or bottle feeding, and then beginning to eat solid foods, requiring a lot of coordination of that oral motor musculature that can be difficult for children whose solid organ disease starts early in infancy or toddlerhood. We also tend to see handedness developing during this time period. Handedness typically starts to show around kind of 2, 3, 4 years of age. And if a clear hand preference is noticed before 1 year of age, it actually deserves a little bit of medical follow-up, because we might worry about some sort of neurological problem like a stroke that's causing weakness on the other side of the body, in fact. Gross motor skills coming along as well, as Dr. Turner mentioned earlier, including balance and coordination. In terms of social and emotional skills, we start to see children moving from parallel play, where they're doing their own thing just next to another peer, to cooperative play, and learning some of that social reciprocity, that give and take, taking turns, and thinking about how others may be affected by our actions. This is definitely ongoing development in this time period, and is challenging for most toddlers and preschoolers for sure. Finally, toddlers and preschoolers are developing some flexibility, as well as some self-regulation, and kind of learning some of those emotional self-control skills. In terms of improving development at home across these areas, there is actually one really interesting study that came out recently, specific to children with congenital heart disease. This study looked at 56 infants with very complex congenital heart disease, and looked specifically at the impact of a cognitively stimulating home environment. And they defined that by a survey that asked questions about things like how often families were reading to their child, the child's access at home to educational apps or toys, and excursions out into the community to kind of expose the child to the world around them. This study found that the degree of cognitive stimulation in the child's home environment was a better predictor of cognitive scores at 22 months of age than the severity of brain injury on the child's brain MRI, which was a pretty compelling finding to me. Of course, this is in a slightly different population with some overlap to pediatric solid organ transplant, but provides some proof of concept and hopefully some groundwork to study the impact of a cognitively stimulating home environment in other populations as well, such as solid organ transplant. In terms of leveraging community and school resources, certainly kind of starting out with that home environment, the home activities is the core. Building upon that, oftentimes children who have solid organ transplant early in life will be eligible for those early intervention services, so physical, occupational, or speech language therapy. Feeding therapy can certainly be helpful, especially if we have feeding tube placement and are trying to wean off of that towards solid foods. Importantly, for children who have difficult medical experiences or even kind of medical trauma early in life, play-focused trauma-based therapy can be very helpful. We don't often recommend play therapy for significantly older children with different psychological difficulties, but to work through difficulties, going to routine office visits, or with non-invasive medical procedures like having echoes or ultrasounds, it can certainly be helpful to do some play therapy around this. And for children who are having behavioral outbursts, tantrums outside the norm for this age, or other behavioral difficulties, behavioral therapy that looks at kind of reinforcement and behavior plans can also be helpful. Finally, on a broader community level, we recommend preschool for children with any type of neurodevelopmental risk. This can be helpful in terms of having an IEP or an individual education program if needed. And I saw that IEPs and 504 plans have been covered extensively in a previous Transplant Families conference, which was a wonderful talk I was able to view. So we won't go into IEPs and 504 plans today. But in addition to the kind of academic and developmental support, the social emotional learning in preschool is really unparalleled. Talking with a lot of families of children who've undergone solid organ transplant early in life, I understand that being on immunosuppressant medication can be a big concern with sending your child into kind of the germ petri dish of preschool. And so certainly this is a conversation that should happen between each family and their transplant provider. But I encourage that conversation to be framed both in terms of the potential risks of infection at preschool, but also weighing against the neurodevelopmental risks of potentially not attending preschool, because there are different risks associated with both options. Moving along to kindergarten and school entry. The skills and milestones that we start to think about at this time period, including really lengthening that focus and attention span to be able to focus on topics for longer. Starting to develop phonics and literacy skills, understanding the sounds that letters make and putting those together into words. Math facts and reasoning, not just memorizing math facts, but for example, being able to look at a group of 2 or 3 objects and just knowing that there are 2 or 3 of them without having to count 1, 2, 3. Starting to form more peer friendships, mutual relationships. Increasing that behavior self-regulation and that frustration tolerance, and even beginning to work on self-advocacy skills, how to stand up for ourselves or for others, or how to talk to other kids about our medical condition or any other differences we may have. In terms of improving development and how to help all these skills develop at home. In the academic realm, we typically recommend incorporating learning into everyday life. So use math when you're counting out M&Ms for dessert or when you're measuring for cooking. Point out letters and words on signs around the community as you're out and about. We recommend keeping very close communication with teachers, even for children who are doing well at school. In this early kind of kindergarten, first grade timeframe, a typical approach for many schools is that if children start to fall behind, they kind of use a wait and see approach because there's just a lot of variation in typical development. But for our kiddos that have any degree of neurodevelopmental risk, we really recommend taking a more proactive approach. And if we start to fall behind, in literacy or math or attention, we recommend initiating intervention sooner to try and see if we can close that gap and catch them back up rather than taking that wait and see approach. Finally, we really recommend starting around this age to praise effort rather than success. So if your child's working on a hard task, jump in and praise their effort before they even get to the end, whether they succeed or not. If they do succeed, praise how hard they worked at it and help them to make the connection between their effort and the result. This can really kind of help stave off or avoid some of that perfectionism or performance anxiety that can come out later in elementary school. In terms of social skills, one thing we encourage is to have play dates with children who are at the same developmental level as your child. And this may be children of their same chronological age or grade, but if your child has any developmental or social delays, this may be playing with friends who are a year or 2 younger, and that is totally okay. In fact, it will probably help develop your child's social skills and social self-confidence even more to have playmates that are at their level and have similar interests. We also encourage just talking a lot about feelings and how to identify our emotions and discuss opportunities for learning from, things that go awry in social interactions together. So if someone gets frustrated and hits a friend, discuss that later at home and what could be done differently next time. In terms of attention span, that focusing ability, we think of attention as being in some ways a little bit like a muscle, and we see if we can train it or kind of help lengthen that attention span. One way to do that is to see kind of for how long your child can focus on a task that is not particularly preferred for them. So of course they can probably play video games for a while, but maybe they can focus on a math worksheet for 2 or 3 minutes. Set a timer for that period of time and have them focus until the timer goes off. Then gradually increase the amount of time on that timer by, say, 30 seconds, each time you set it, to help them focus for longer and longer periods of time. We also know that exercise tends to boost focus, both in the short term. For example, taking active breaks between focus times can help kind of refresh the brain. And also for the long term, regular cardiovascular exercise has been shown to improve ADHD symptoms in the general child population. Also, during times of focus, having fidgets or being able to move about, sitting on an exercise ball, those sorts of things can all be very helpful to aid focus. The areas in the brain that kind of regulate body movement also help regulate your focus and attention. And so engaging those in movement can help with focus, particularly for kids with attention difficulties. And finally, working on self-advocacy and self-regulation skills. Definitely recommend starting to work on the adaptive functioning early on at this time frame with age-appropriate chores and responsibilities, and teaching your child scripts to stand up for themselves and for others. What they will say if a child asks about their scar that might be visible when they wear a tank top, or what to say if a peer is being unkind to another friend. Giving them some of those scripts can be helpful. Finally, in terms of leveraging community and school resources at this age, a neuropsychological evaluation can be a great jumping off point to really understand your child's cognitive strengths and difficulties, and plan for interventions to help optimize their neurodevelopment. This can result in recommendations for an IEP or 504 plan at school, therapies outside of school, other social groups or activities, as well as behavioral health service referrals. Now I am going to turn it over to Dr. Turner to talk a little bit more about transitioning after elementary school.
Yeah, perfect. I will jump into talking a little bit about middle school and how to support kids at this age. And so one of the kind of key cognitive skills that becomes really important starting in middle school is that executive function skill that Dr. Wolfe and I talked about on previous slides. So really executive function is an umbrella term that includes all of the different cognitive skills a kid needs to complete a task or get something done. And so I have some examples in my diagram here of all of what those types of skills can include. But as I talk through them, I'll share within the lens of an example. So if you are a parent and you're giving your kid 3 chores to do at home, one of the skills that they'll need is task initiation. So they'll need to be able to get started on those tasks. They'll need to plan out how much time they need. So some of those time management skills, but also all the steps involved in each of those chores. They'll need to kind of organize those steps so they go in order. And they may need to organize whatever materials they need to get those chores done. They'll also need to do some monitoring to make sure that they're hitting all of those steps and doing it in a time efficient manner. And so in middle school, kids are really expected to take on more at home and at school and to do it independently. And that's why these executive function skills really come into play. And on my next slide here, I have some examples of how executive function can impact daily life for a middle schooler. So I've already touched on the home piece a little bit. So having difficulty getting chores done is something you might notice, or having a harder time with multi-step instructions. You may notice as a parent, you're breaking down tasks into individual steps and that your kid can follow through with that a lot easier. Kids may have a harder time organizing their personal items or room and keeping track of things like their medication schedule or daily schedule altogether. In the school setting, executive function can impact a kid's ability to keep track of their assignments or deadlines. They may have a harder time planning for bigger projects or exams that come up in middle school. And we actually see some of these executive function skills start to come into play in the actual academic work they're doing too. So writing assignments or essays become longer, and kids need to kind of organize their thoughts or arguments for these essays, and then organize the order and flow to make sure that it makes sense. Math assignments or math problems can often become multi-step, and they need to kind of organize those steps and plan for them as well. So for the school For school supports, I know Dr. Wolfe mentioned kind of 504 plans or IEPs can come into play early on in elementary school, but as kids shift into middle school, the emphasis in these support systems really switches from intervention to accommodation. And accommodations for these executive function skills can be really important as the demands and expectations go up at school for middle schoolers. So this can include breaking down assignments into individual steps and having these steps or other to-dos in a written or visual to-do list. So kids can refer back to that to help them self-monitor how they're doing and getting things done. Schools can also provide some more formal communication with home so that parents are aware of bigger deadlines like projects or exams and can help with some of that planning process. For organization difficulties, having access to teacher or peer notes can be helpful so kids can kind of focus on the lecture in the moment, but not really have to organize their thoughts or their notes about what's important and have some of those key takeaways provided for them. Graphic organizers are also a really great tool for things like reading comprehension or writing at this level of schooling. Interventions are still possible in middle school, and some focus on executive function can include like a study skills period or a dedicated time with a learning specialist where a child's getting some direct coaching and how to use planning or organization tools like calendars, different types of planners, or binder and folder systems to keep track of all of their things. This specialist can also help a kid break down projects or exams into mini goals so that they're prepared along the way and not waiting until the last minute to get something done. Home supports are also really important for executive functioning at this age. And you may look at all of these things I have listed here and think these are things that I use in day-to-day life. And we don't all have executive function challenges. But for a kid who does, then kind of figuring out these types of strategies and getting them implemented in a more regular fashion can be a little bit harder. So they're going to need some more supports in these areas. In the dark blue, some of these are really similar to what I presented on the last slide for school. So having written or visual checklists or a calendar or planner available to your child can help them know what to expect and kind of monitor what they're supposed to be doing day to day. For organization difficulties, having designated locations for key items can be really helpful so kids know where exactly to find something at home and where to put it back as well. Also having labels around the house for things like different bins in their room or folders for completed homework or homework in process can be really nice so that they can kind of reference labels before always coming to mom and dad first to find something. Alarms and reminder systems can also be really helpful for kind of routine activities or expectations like medications. And reminders can be from a parent or family member, but also using technology like a smartphone or smartwatch your child might have, or things like Google Home or Alexa can have routine reminders in there. Simplifying tasks by breaking them down into individual steps can make things a little bit easier for a kid to get started on and know what's expected of them. So for example, if you're asking a kid to clean their room, that can be a little bit vague and overwhelming, and they might not know what to get started on first. So making it clear that you want them to make their bed and you want them to put dirty laundry in the laundry basket can make it a lot clearer for them. Routines also can make things a lot more automatic. So they know what's expected of them first thing in the morning when getting ready for school or when getting ready for bed. And then you don't have to give as many prompts and reminders as a parent. I next want to talk a little bit about medication adherence. So we know that these executive function difficulties can interfere with medication adherence starting in these preteen years, really across chronic illness populations. In middle school, we really expect parent to still be the primary manager of medications. Developmentally, children should be expected to take their medication and they can help fill a pill box if that's something you're using. But really, parents are still going to be primarily responsible for giving reminders for taking meds and ensuring that they've been taken by either watching their child or by checking the pill box after it's been taken or before they head off to school. I have some of the strategies from my previous slide listed here that can be really helpful for supporting medication adherence at this age. And then having like a checklist or a designated location for the medication that is easily visible or accessible to the child is important. So it's a little bit more of a visual prompt or reminder for them to do that activity. If taking medications on time is something that's challenging for your kid or family, then connecting with your pediatric psychologist at your transplant center or hospital can be really nice, and they can brainstorm some of these strategies, but also things like ways to use praise or reward systems to support getting medications taken on time. And my last slide for middle school is social functioning. So this can be a tricky age for any preteen, but for those with chronic illness, they can start to notice that they feel a little bit different than their peers. Again, maybe they have a scar, or they notice they're taking medications that other kids aren't. They may have physical restrictions, or their medication regimen may impact what they're able to do socially. And they may be unsure about how to talk about their illness with others. And of course, bullying and teasing is something that comes up for all children at this age. So as a parent, what can you do to help? So encouraging spending time with friends and developing close friendships is really important as they transition to middle school. Extracurriculars are a great way for kids to get connected with peers that have similar interests of them to kind of facilitate those friendships. It can be helpful to problem solve any barriers to them spending time with friends. So what to do if there's a sleepover that comes up and they need to take medications at that time. It can also be really nice to have some scripts in your preteen's back pocket on how to respond to questions about their illness. And they may have a script for a more trusted individual that they want to share more with, and they may have a script for someone that they don't know as well. Bullying and teasing can be really difficult to navigate as a family, but keeping an open line of communication and checking in about bullying and teasing can be really helpful. Involving school personnel is something that's also recommended when bullying is occurring, and that might not be the choice that your child wants, but letting them know and talking through that decision with them can be helpful, as school personnel can maybe buffer some of that bullying or prevent it at school, but then also get them connected with someone like a school counselor who can give them support if that does happen at school. All right, next I'll talk about that transition to high school. And I'll start off by saying that executive function supports are still very important. So demands go up and high schoolers are expected to do more on their own. You may notice that your child really gets into a rhythm of using some of these strategies in middle school that are working well. And when they transition to high school, they're not as effective. And that's okay. And that's pretty normal. Sometimes those demands change and go up. And so we just have to revamp kind of what strategies we're using or how we're implementing to make them effective again. In terms of what to focus on, and actually, Dr. Wolfe, I think there's one other slide before this one. Perfect. Yep. What to focus on in school. So the emphasis is still on accommodation over intervention. But I do want to mention that accommodations can be made available for tests like the SAT and ACT through the College Board. This is a formal process with paperwork that needs to be submitted from your child's school to receive these accommodations. So this needs to be done in advance. It can also be helpful to have a repeat neuropsychological evaluation at this time so that your neuropsychologist can make some additional recommendations and make a case for these accommodations for this testing. These accommodations are really similar to what would be available to them at school, like extra time, breaks during tests, being able to take the test over multiple days in a distraction-free room, or things like access to food, water, and medications as needed. We also really emphasize self-advocacy at school for high schoolers. It can be helpful for them to start to participate in their 504 plan or IEP meetings so they're familiar with what accommodations they have. And having some nice scripts in their back pocket on how to ask for accommodations can make it easier for them to request different things. Sometimes you can get connected with a point person at school like a counselor that can help by starting to do that asking for them and gradually kind of transfer over some of those self-advocacy skills. I'll touch on a little bit of what can be helpful to focus on at home at this age. So this is really increasing their independence and daily living skills. And we recommend a 3-tiered system. So we want teens to have lots of opportunities to observe parents modeling these skills. And then that can gradually get shifted to them where they're doing some more supervised attempts of these things. Once they've really mastered that skill, then they can do it independently. But focusing on things like house management skills, like cleaning, laundry, cooking, budgeting any money that they have coming in through work or allowances, and then transportation. So whether that's learning to drive and the responsibilities that come with having a car or public transportation can be really helpful. And then, of course, some of those time management skills are prepping for travel, especially with their medications. In terms of medication management, that 3-tiered system also works really well in this area. So we really want parents and teens to become co-managers of medication in these high school years. So through observation and supervised attempts, teens can gradually take on more, like filling their medication box, taking medications more independently, learning how to do a refill at a pharmacy. They may be taking the lead more in their medical appointments, and it's helpful for them to learn a little bit more about their condition and why they're taking the medications they are. Cincinnati Children's has recommended 4 different phone apps that they have listed here on the right-hand side that can help with medication management. So teens can enter their medication schedule, and there can be alarms and reminders set on it, prompts for refills, and they can check off when they've taken it, and a parent can see it on their companion app. Okay, the last piece that I'll talk through is that transition to adulthood. And so so social functioning, one more slide left. So there can be a lot of different things that come up socially for teens in high school. So there's different social pressures like engaging in risky behaviors or drug and alcohol use, as well as more social media use. As a parent, it can be helpful to think through kind of more harmful or positive social pressures. So harmful social pressures are ones that we may think about kind of typically sneaking out, skipping class, drug and alcohol use, where some of their friends might engage in more positive social pressures, like encouraging them to try out a new extracurricular activity, like joining the school play or taking on a leadership role in a club. And so really honing in on who are their friends that really encompass this positive social pressure, and encouraging time with them can be helpful. It's also nice to have conversations about different risky activities and how that might impact your kid's health or their medications. And having some scripts that your child can use to respond to different peer pressures, like what to say if they're asked or pressured to drink at a party, can be really helpful as well. Having a family bailout code phrase is a nice discreet way that your teen can let you know that they're uncomfortable and they'd like you to come get them or help them get out of a situation. And they can text this or say it over the phone with you. And there's different ways to monitor social media use too. So I have listed here on the bottom right-hand side. So SafeWise puts out recommended social media monitoring apps for parents, and this is their 2022 list. Unfortunately, these apps do have an annual fee, I think with the lowest starting around $40 to $50 a year. But what they can do is they can limit time on social media apps or restrict certain apps. And they can also monitor some of the content in text messages or social media messages. So it can alert you if there's any inappropriate content or things related to suicide or bullying. Okay, now I'll talk about transition to adulthood. So there are academic supports available at the college level, whether that's a four-year university or a community college, very similar to what's available in high school. And most colleges have a disability or learning center that puts together these accommodations. It's really helpful to contact this center in advance before the semester starts, because they'll probably want things like a current 504 plan or IEP and a recent neuropsychological evaluation. You can also ask this center about any formal peer tutoring options through them, or something like a writing center on campus, if that would be helpful for your child. If your child is entering the workforce, employers are also required to offer some level of accommodation, and this can really include a variety of things. So physical modifications to the job, extra job training, flexible scheduling, or modified duties. And some of these accommodations can be really similar, can be helpful to think back to what was helpful in high school and implement it on the job too, like having checklists for tasks, helping prioritize or plan which job duties are most important, having copies of work trainings or instructions, and extra time. The Job Accommodation Network is a really helpful online resource for these things. And when helping your child through different career options, it can be helpful to think about what their strengths are. So if your child has some really strong verbal strengths, then a job where they have to really effectively communicate with others or present to teams could be a great fit for them. In terms of medical responsibilities, so in adulthood, patient or your child really becomes the CEO of their medical care. So they are the primary person responsible for making appointments, making decisions, managing their medications, and communicating with their providers. And parental support can be provided as needed. And there are kind of informal ways to do this, with just kind of being a resource for your child. But if you feel like some of these responsibilities are a little bit too much for your child at that transition age, I'll talk about in a couple slides what to do. Transitioning to living independently is something that comes up for a lot of adults kind of at that transition age, or 18. And we talked about building some of those daily living skills on a previous slide, but there's a lot more that comes with actually moving out of the home. And so some of these things include like really understanding their living expenses, including utilities and Wi-Fi, learning how to save money or manage a credit card, understanding their public transportation options, and making sure they're keeping track of work responsibilities. So if you feel like some of these medical or independent living skills would be kind of too much for your child at that transition age, there's a couple options for staying involved in a more formal sense. So guardianship and power of attorney, and these are both legal options. So guardianship is a little more involved on the legal end, and this is often presented in front of a judge who can make a parent or parents or other adults guardians. So several rights are lost for that individual at this time, and so the guardians are the ones who are legally consenting to things and making major financial and medical decisions. This is not permanent, but it is harder to discontinue. In terms of power of attorney, this is also a legal process, but is usually less involved, and only some states require it to be presented in front of a judge. This can be situation specific, like just making medical decisions or just making financial decisions, or maybe just give you the opportunity to make medical appointments without being the primary decision maker. This can be discontinued a lot easier at any time. I have some questions on the right-hand side that can be helpful to think through when wondering if guardianship or power of attorney is a nice option for your family. So it can be helpful to think about your child's kind of day-to-day reading and math and whether that would interfere with their ability to do things like sign a lease for an apartment or understand a utility bill. Think through whether they'd have a hard time making bigger financial decisions or consenting to different legal agreements. And thinking through whether they're at risk for being taken advantage of financially or in other ways. And that is all that we have. I want to thank everyone for joining and listening to us today. And thank you for the organizers for giving us the opportunity to talk through this information. And Dr. Wolfe will be available for questions.
Thank you so much for this presentation today. It has been wonderful. I'm going to flash up a few questions. I know we're running late, and we appreciate everyone's patience with us. So we'll start with, how do we request a neurocognitive assessment? If there isn't a program in our center, who should we point our team to?
Yes, thank you so much. And thank you everyone for your patience with my technical difficulties this morning. This is a great question. Almost all children's hospitals have a neuropsychology clinic that serves children with lots of different types of medical conditions that can impact their neurodevelopment. So even if there is not a transplant-specific neuropsych program at your center, there will almost always be a neuropsych clinic that just sees a variety of children with medical difficulties. And so I would recommend, as a first step, talking with your transplant coordinator or provider to ask about getting a referral to that clinic. There are also pediatric neuropsychologists in the community who can, provide very good care, but they tend to not be as well versed in the neurological difficulties that are associated with specific medical conditions and treatments, and are just not as integrated in the medical system. And so I always recommend starting at your children's hospital first to get that neuropsych evaluation.
That's great advice. All right, I'll flash the next one up here. At what age should your child have their first assessment?
Yeah, this is a great question. I get this a lot too. So it is never too late for a neuropsych assessment, first of all. So if you have, I often see, teenagers or even young adults in college who have never had one, and they are just kind of coming to realize some of the cognitive difficulties that they've been having might be associated with their medical condition, or just didn't know about our clinic before, since this is a developing field. And so I say it's never too late to help, to find out more about your child's neurodevelopment and kind of help optimize their long-term outcomes. But if you are starting, kind of from early in life and thinking about this prospectively, the kind of spring and summer before kindergarten entry is a really good time, even if you don't have major concerns. In the world of congenital heart disease and at our Center for Solid Organ Transplant too, we try and think of this as like a developmental checkup before going to kindergarten, just like you routinely see other medical providers, even if there aren't concerns. That pre-kindergarten timeframe is a really nice time to get a good assessment so that we can pick up on any even like slight or mild concerns that could benefit from some accommodations or proactive intervention going into kindergarten. And also, if everything is looking great, then you have that reassurance going into kindergarten that you've kind of, checked all the boxes and can expect that it will be a smooth transition.
Thank you so much. I know I want to be respectful of everyone's time and get you to your other sessions. Thank you so much, Dr. Wolfe, and hopefully we can have you back. We'll answer all the questions offline and include them in our our YouTube link that will be going up shortly. Thank you so much today. We finally get to ask you these questions, and we've been looking forward to talking to you for quite a long time.
Oh, well, thank you so much for having me.
We'll see you later.
Bye-bye.
Bye.